Hi everyone, it's great to be here virtually. I hope everyone's doing well considering the circumstances. I'm delighted to be invited to the Future Human Conference. I'm going to speak a little bit about maybe the future of healthcare, particularly the kind of human centricity that we're seeing emerge in some of the disruptions in healthcare. I think it's really important when you talk about the future of healthcare in terms of how it's maybe going to be innovated or disrupted or transformed indeed, is to think about why, and the imperative, the reason why transformation and disruption is so urgently needed in healthcare and the imperatives driving it. If you think about this statistic alone, over 250,000 people die every year from avoidable medical error in the US, which is a really significant amount of number. It's hard to find similar data reported here in Ireland. One report is that it is averaged around 1,000 deaths per year, which is 7 times the road fatality we have in this country. So an interesting data point to be considering. But I worked in the area of experience a lot in health and in healthcare, the patient experience, and often the experience of treatment in healthcare, particularly around trauma and procedures, is worse than the experience of the disease. And really impacted, and potentially we put too much emphasis on trying to tweak an experience in a model that is fundamentally broken. This was once said to me by a patient: "You saved my life, but you almost killed me doing it." And there's this idea that the body remembers, and particularly with children when they have medical encounters, but also just in general, the impact in terms of going through medical procedures, and the PTSD is often experienced by people as well. And so just acknowledging that the patient experience is something that it can be quite terrifying and quite traumatic to be ill. We also know from chronic disease that it's not just the traumatic, but just the long-term implications and consequence of being diseased, and the stigma and the isolation that comes from that, and the impact on a person's identity is significant. We understand this a lot from studying chronic disease. And then also, there's just this perception that health is something that you spend to live, that it's a finite resource, and it's depleted through life. And a lot of times when you talk to patients, there's conversations about the degree to which they're aware of the trade-offs that they have made in their life and how they link those trade-offs to a depleted health. And there's a strong sense of guilt associated with that, which is really unfortunate. Also, health fatalism. We also know that health, it's not just feeling good, it's feeling good about yourself. It's strongly linked to a sense of identity and a sense of purpose. And we know that the World Health Organization recently warned that depression will become our #1 chronic disease globally and the single greatest source of disability by 2025. I think there's, relatively good conversation emerging, particularly kind of due to COVID, around the topic of mental health and the importance of it. But when you think about when people die of depression, we call it suicide. We obviously need a new narrative. We need a lot more compassion, and we need a different way of talking about mental health as a disease, and treating it as a disease, and caring for people with a lot more compassion. And then there's the whole area of longevity, which is really interesting because medicine has been so effective at prolonging life. And there's been this kind of war on aging. What we're seeing is that people are living longer lives, and indeed most, the current generation, most people are surviving diseases that would have killed their parents. And what's happening is we really are starting to encounter this idea of the loss of independence and indeed dignity at the end of life. And it's a kind of philosophical, it's an ethical conversation potentially, but it is kind of where, kind of society and medicine intersect. And certainly something that needs to be considered and potentially innovated around. But medicine's got a really, really complex relationship with change. And so I've worked in healthcare innovation for about 15 years. And it's not, it's an industry that has a complex relationship with the idea of change. It's highly regulated. It's very risk adverse. It's based on the principle of expertise, and it's quite institutionalized. And all those things make innovation very, very difficult. It's a very complex system. And often what you see in super complex systems, what they call polycomplex systems, is that they're often very, very hard to innovate. And what happens is you see a redistribution of complexity versus an actually kind of eradication of complexity. And so healthcare is so complex that more and more innovation is actually just the redistribution of complexity. And an example, case in point, would be the idea that an awful lot of kind of burden of care is shifting to patients and their families. and the idea of kind of care in the home, and the degree, particularly around chronic disease, where the burden of care is shifting back to the patient. There's also a really complex relationship in healthcare with technology. I mean, typically, if you think about a lot of what's considered big tech in medicine, they're often kind of doing tools versus thinking tools. And I think, what's going to be most interesting is that the kind of tools that are emerging and that are kind of emerging in the healthcare space are the thinking tools. There's a principle in innovation around additive versus disruptive. Additive tools are a lot more tolerated culturally. They get added into the system. They don't necessarily threaten the status quo. They're not destructive. They're not reductive. They don't make things redundant. A lot of emerging technologies are really looking at the idea that there'll be a lot of redundancies as a result of them arriving in healthcare. A big part of what we're challenged with in terms of, in the healthcare space is that the kind of limitations of the human cognitive capacity. So, this may be relatively controversial, but one of the biggest kind of pinch points in the healthcare system is the human, is their ability to understand and to know things at scale. And if you think about right now as one particular data point, you may have a 6-month waiting list, for example, to see a specialist in the private healthcare system here in Ireland, and probably a 2-year wait list to see in the public healthcare system. That's particular to dermatology as one example. And so you think about, it's not because we don't understand dermatology in the care model, it's just because there's aren't enough dermatologists. And so again, you think about being able to scale care. We're actually at a point where scaling care with a human model is just not working. There's 2 types of journeys that healthcare is going to go on. It can either transform itself or it will be disrupted from outside. And what we understand about innovation is institutions that do not transform themselves are ultimately disrupted from outside. And I think that's what we're going to start to see happening. You start to look more at the kind of space of the kind of general area of emerging tech. And for generations, we've thought humans had to understand technology. They've obviously, it's been like servant tools. Moving forward, our tools are becoming incredibly intelligent and autonomous, and we'll teach them how to understand us. So one example of that is they think about computer vision. Computers can see, and not just see in terms of cameras, but they can recognize. They have kind of a digital brain. So the areas we're seeing really radically disrupted and quite rapidly: ophthalmology, dermatology, radiology, pathologies. All of these different medical specialties are based on image recognition and pattern recognition. And so you start to think about the compatibility and the significance of computers being able to do this. And back to this idea of scale and access. What's also amazing about computer vision is that they're not just great at pattern recognition, but they make unusual associations. So, it's very, very difficult to find the level of expertise. It's rare that someone would have the level of expertise that they would be able to make really what's considered esoteric associations of medicine. It also takes a lot of time. And so for individuals, for clinicians to be able to be that good in their area of specialty and have the time it takes to do that is just not feasible in the current model. And so again, we're starting to see kind of computer vision and the associative effects of being able to process this amount of data as being really radical. Second big disruptor is really software is becoming the new pharma. If you think about this idea, we've talked about this journey from tools to therapies. We've understood that technology has come into healthcare as a tool, again, a servant tool. And it's moved more and more into actually becoming medical devices and into therapies itself. And I'm particularly excited about the idea of digital therapy. I think because it's safer, it's faster, which means it's much more accessible, it's cheaper, which makes it more accessible as well and more feasible. It can be instantly personalized to the individual. I mean, an awful lot of pharmacology is very generic. This is very individually personalized too, and it's non-addicting, and it's being used an awful lot in rehab, particularly around pain, because of the opioid addiction, and we understand the significance of that and the implications and the impact on the individual. So finding an alternative that has, essentially is this scalable and this effective is really significant. One of the most interesting things that are happening in disruptive diagnostics is digital biomarkers. And so you think about what we understand about people, the clinical data we understand about the individual, about the patient. So they have a phenotype, which is basically, what's determined genetically. Digital biomarkers are the things that we can measure of a person. So that would be, blood pressure, heart rate, oxygen saturation, temperature, all the data that a body gives off, the physiological data. What's entered this space in terms of diagnostics is digital biomarkers. And this is all, a digital biomarker really refers to the data that is coming off your digital devices. It's basically objective indications of your physiological, cognitive, and even your emotional state as observed from the data off the devices you're using. And an example of this would be movement, sleep, isolation versus connectivity, the environment you're in, your levels of stress and anxiety, if you have any obsessive compulsions, addictions, mood, and again, thinking about camera technology, face recognition, sentiment analysis through the voice, your voice analysis, all these things are possible even through a simple smartphone. So digital biomarkers, they're multimodal. So this is the space where the kind of medical wearable is really going to come into its own. I think it's going to be a really significant space for medical wearables and medical IoT. Multimodal, continuous data being captured on these sensors, making a signature. So these become a signature or a much earlier indication of disease, even if you're asymptomatic. So asymptomatic means that you don't have any clinical symptoms established. The significance of digital biomarkers probably can't be underestimated in terms of how disruptive it's going to be to the traditional principles of diagnostics. And so if you look at the chart on the left, you know, the original, the kind of shape of healthcare, I mean, an awful lot pivots around the point of diagnosis and back to this idea of kind of biomarkers. So much of diagnosis is effective when symptoms are present. And so an awful lot of what happens with a sickness model of care is that ultimately you have to be sick before medicine can be really effective. And so, you know, the establishing of the disease often happens before there's any symptoms. It's called being asymptomatic. And so you think about at a certain point when you are aware of symptoms and the disease is established and can be quantified and can be named by the medical profession is where medicine is most effective, because once the disease is understood and named and identified and the degree to which it's established and its trajectory within that patient can be anticipated, medicine can be very, very effective. And so that is a sickness model of care. And it's a model of care that we've used for over 100 years. You start to think about what's happening really disruptively, where if you take that point of diagnosis and you move it, you know, really radically earlier. So you're looking at the idea of digital biomarkers may be very weak signals that are trackable and traceable and perceivable to the devices that we use, and that are signatures of early indications of disease. So if you think about something like gait analysis, for example, people are understanding that more and more gait analysis is an early indication of Parkinson's potentially. If you think about sentiment analysis, an awful lot of understanding around kind of psychological conditions, particularly kind of around kind of depression, is often linked to, you know, very subtle changes in tone, subtle changes in phrasing. Again, algorithms can be kind of calibrated to understand and to kind of basically watch. It also helps to show to capture the progression and speed that these signals are becoming established. And so what the significance of thinking about, you know, where diagnostics start to shift to being significantly earlier is that you start to imagine that if diseases were perceived and identified potentially years earlier, what therapies exist to respond to that. You know, traditional diagnosis is where you kind of start to kind of turn on all the kind of clinical and medical services, which are very effective. If you think about, if you were to identify the disease significantly earlier, what therapies and treatments do we currently have in place to respond to that really, really early diagnosis? This is pretty much the new frontier of medicine. I mean, this is a space that is uncharted. We don't necessarily understand the new therapies that we're going to need to develop to respond to this early diagnosis. It's a new medical frontier. What's interesting about it is that no one currently occupies it. It's definitely going to be a space where there's more and more kind of activity based in terms of thinking about digital therapies. It's a place where the future of medicine is going to be defined and determined as in this particular space. The future of medicine will be an adjacent, alternative, and autonomous model. It will not be the traditional model of care. Thank you.